Imagine a 60-year-old patient who has maintained highly elevated levels of bad cholesterol their entire adult life. Yet when they undergo a standard clinical scan, their coronary angiogram shows a perfectly open, glowing vascular tree. Their coronary artery calcium score, a scan used to detect calcified plaque in the heart, comes back at absolute zero. In standard clinical practice, this specific imaging presentation is frequently interpreted as an absence of biological risk. A doctor might assume this patient possesses some localized, physiological immunity to the buildup of arterial plaque. However, forensic autopsy data directly contradicts that assumption. The PDAY and Bogalusa heart studies, two major epidemiological research initiatives that examined the physical arteries of deceased individuals, tell a vastly different story. These forensic cohorts demonstrated that microscopic fatty streaks, the earliest biological evidence of arterial disease, are already present in nearly all adolescents examined. By the time a person reaches their 6th decade of life in a westernized population, pathologically pristine coronary arteries are virtually non-existent. Diffuse lipid deposition is ubiquitous. A pristine angiogram in a high-risk 60-year-old represents a diagnostic illusion. This illusion is created by three distinct factors: the physical resolution limits of standard clinical imaging, the compensatory hemodynamics of the blood vessels themselves, and a widespread medical misunderstanding of what arterial calcification actually represents. Relying strictly on imaging that only looks at the hollow center of a blood vessel creates a clinical blind spot. It leads practitioners to confuse invisible, microscopic disease with absent disease. To understand why the disease remains hidden, we have to look at the cellular mechanics of plaque formation. The medical consensus establishes that atherosclerotic plaque is driven by prolonged exposure to apolipoprotein B-containing lipoproteins. Apolipoprotein B, or ApoB, is a structural protein attached to every single atherogenic or plaque-causing particle in the blood. This chart highlights the difference between the two primary lipid metrics. LDL-C on the left measures the total mass of the cholesterol payload, but ApoB on the right measures the exact number of atherogenic delivery vehicles circulating in the bloodstream. The physics of subendothelial trapping dictate that the probability of a particle getting stuck inside the arterial wall is a biological equation: particle concentration multiplied by time duration. This mathematical accumulation is quantified as ApoB years. It is a metric of cumulative vascular exposure and physical arterial damage. In cases of clinical discordance, situations where a patient's total cholesterol mass is relatively low, but their ApoB particle count is high, ApoB is the more accurate predictor of a future myocardial infarction. Evaluating a patient's risk based solely on the mass of their cholesterol overlooks the biological probability of plaque formation. Plaque is driven by sheer particle burden, not payload weight. If a high ApoB particle burden leads to plaque formation, we have to explain exactly where decades of those trapped particles are hiding in a patient with a perfectly clear angiogram. The answer is the Glagov phenomenon, also known as compensatory outward remodeling. As lipid deposition begins in the subendothelial space, the coronary artery actively attempts to preserve its internal blood flow capacity. To do this, the outer boundary of the blood vessel expands outward, keeping the central channel completely unchanged. The vessel continues to physically expand externally until the plaque burden exceeds approximately 40% of the internal elastic lamina area. The internal elastic lamina is the outermost boundary of the artery's inner wall lining. Standard invasive angiography and visual CT scans are strictly designed to image the central lumen, or the hollow space where blood flows. Because the vessel expanded outward, these tools render a perfectly uniform tube, while the plaque sitting right beside it remains invisible.
Narrowing of the actual blood pathway is delayed until that 40% structural threshold is breached. These concealed, outward-growing plaques are heavily lipid-rich. They are biologically active, structurally unstable, and prone to rupture. An angiographically normal artery simply means the vessel has not yet exhausted its outward expansion capacity. It masks a biologically active plaque burden from standard imaging tools. This brings us to the coronary artery calcium, or CAC, score. This metric is widely utilized as a population-level risk stratification tool. This chart from the MESA cohort data plots the coronary artery calcium score against long-term event risk. It shows a graded association between heavy calcium burden and coronary heart disease, with a spike in risk starting at a score of 300. But long-term probabilistic data across a population does not neatly map to the short-term acute reality of an individual suffering a heart attack. Looking at this pie chart representing all acute coronary syndromes, we see a specific statistic. Approximately 25 to 30% of these heart attacks occur in individuals with absent or minimal baseline calcification. This reveals a temporal disconnect in plaque pathology. Calcification does not indicate a new dangerous plaque. Calcification represents chronicity, vessel healing, and structural stability. The structures most prone to near-term rupture or erosion are non-calcified, soft lipid-rich plaques. These are particularly prevalent in patients with high ApoB particle counts. Consequently, a CAC score of 0 in a high ApoB patient does not guarantee immunity from a cardiac event. It indicates a delayed expression of calcification over a non-calcified base of plaque. To pierce the Glagov illusion, medicine requires technology that analyzes the vessel wall itself. This is achieved through artificial intelligence quantitative computed tomography, or AI-QCT platforms, such as Clearly. By enabling precise volumetric plaque quantification and compositional analysis, AI-QCT achieves an accuracy approaching invasive intravascular ultrasound. Intravascular ultrasound, or IVUS, is a procedure where a tiny probe is threaded inside the artery to map the exact dimensions of the vessel wall. A recent cohort study involving roughly 750 patients compared the standard visual interpretation of a CT angiogram against the volumetric analysis of an AI-QCT platform. This side-by-side comparison shows the quantitative reality. On the left, visual scans identified 159 patients as having no plaque. On the right, after advanced volumetric assessment, the true number of pristine arteries fell to just 58. The revelation of this hidden data led to a direct diagnostic modification in 39% of the total cases. Advanced volumetric imaging reveals that visually normal angiograms systematically hide clinically relevant non-calcified plaque burdens. This hidden non-calcified plaque connects directly to a specific clinical syndrome known as MINOCA. MINOCA stands for myocardial infarction with non-obstructive coronary arteries, representing heart attacks that occur in vessels lacking severe blockages. The scale of this threat is substantial. MINOCA accounts for roughly 5 to 15% of all acute myocardial infarctions. The pathophysiology here is precise. These small, visually unobstructed plaques undergo sudden endothelial erosion. The delicate surface tears open, triggering localized blood clotting or thrombosis, without any prior luminal stenosis, meaning the artery was never previously narrowed. Crucially, ApoB remains a predictor of heart attack risk even in patients who lack obstructive narrowing disease. For a 60-year-old patient with high ApoB, relying on a clean angiogram and a 0 CAC score is a diagnostic illusion. It is an artifact of the limits of imaging resolution and the masking effects of compensatory remodeling. Elevated ApoB with minimal visible plaque represents a latent risk. Managing that reality requires personalized preventative strategies that address the invisible particle burden now, rather than waiting for a luminal obstruction that may never arrive.